Hi, today we're talking about bipolar and depressive disorders, and we're going to cover diagnostic criteria and differential considerations. So, feeling down or moody is something almost everybody can relate to. And these experiences are so common that they make us question where the line is between normal emotional responses and diagnosable mood disorders. How do we distinguish depression from sadness? How do we separate bipolar disorder from the typical ups and downs of life? And is depression always a standalone disorder, or could it be a symptom of something else entirely? So, to give you some perspective, it's estimated that if we could somehow eliminate depression altogether, we'd reduce global death and disability by about 10%. And that's a staggering statistic that highlights how impactful mood disorders are, not just on individuals, but on society as a whole. So, in this lecture today, I'm going to break down the diagnostic criteria for depressive disorders and bipolar disorders as outlined in the DSM 5 TR. And there's a lot to unpack in these chapters, but we'll explore the ways that these disorders overlap and differ, helping you understand how to approach them in practice. So, we'll start by looking at the types of depressive disorders. So, that's major depressive disorder, persistent depressive disorder, which now combines chronic major depressive disorder and dysthymia, disruptive mood dysregulated disorder, which we touched on the video on disruptive impulse control and conduct disorders, premenstrual dysphoric disorder, substance medication induced depressive disorder, and depressive disorder due to another medical condition. And then we're going to look at bipolar disorders. So there's bipolar I, bipolar II, and cyclothymic disorder. And for both depressive and bipolar disorders, we'll also discuss substance induced disorders as well as the other specified and unspecified disorders that don't neatly fit into the standard criteria. One of the key things to keep in mind is that while these disorders have clear diagnostic criteria, it's essential to step back to make sure that what we're seeing really fits. For example, if someone presents with depressive symptoms, we need to consider whether an underlying medical condition like hypothyroidism might be driving their symptoms. Context matters. In all depressive disorders, the common thread is a sad, empty, or irritable mood, along with clinically significant symptoms. What differentiates these disorders are factors like the duration of symptoms, their timing, the presumed cause, and the number of symptoms required for diagnosis. For instance, persistent depressive disorder has a much lower symptom threshold than major depressive disorder, but it happens chronically over a longer period of time. When we move to bipolar disorders, things get a little more complex. Bipolar disorders include periods of depression, but add mania or hypomania to the mix. And to really understand bipolar disorder, we first need to have a solid grasp on the nature of depression, and that's where we're going to begin. So let's start with major depressive disorder, or MDD. One of the key challenges is distinguishing depression from sadness. And a helpful way to think about this is that depression involves a mood that's clearly disproportionate to external stressors and persists over long periods of time. It's not just about feeling sad, it's a persistent, pervasive state that impacts daily functioning. And we want to look at grief versus depression because these two things seem to overlap. This is where we encounter a common debate. Should depression be diagnosed when a person is reacting to a stressor like the loss of a loved one? Earlier versions of the DSM excluded depressive episodes following bereavement, but this exclusion didn't extend to other types of loss like divorce or job loss. Now, the DSM 5 TR recognizes that depressive symptoms triggered by any significant stressor can still meet the criteria for MDD if they are severe and persistent enough. And this helps distinguish what is a normal reaction from what has crossed into clinical territory. And to meet the criteria for MDD, a person must experience 5 or more symptoms causing clinically significant distress or impairment for at least 2 weeks. These symptoms can't be due to a substance or medical condition. A striking fact: up to half the population may meet criteria for MDD at some point in their lives. So, the symptoms and features of MDD. The core feature is a depressed mood, and often described with words like sad, empty, hopeless, or miserable. But depression is more than just a mood, it involves disturbances in multiple areas. So, starting with sleep, over 90% of people with depression experience sleep disturbances, including difficulty falling asleep, early morning awakenings, or sleeping too much. Anhedonia, this is the lack of interest or pleasure in activities, even those that used to be enjoyable. It's what makes depression feel non reactive. Positive events don't lift the mood. And then there's guilt or hopelessness. Depressive thoughts often focus on feelings of worthlessness or excessive guilt, with rumination being common. There's going to be changes in energy. Severe fatigue is almost universal, making basic activities like getting out of bed feel insurmountable. When looking at concentration, people often describe a foggy mind, which impairs their ability to work or maintain relationships. And most people with depression experience a significant decrease in appetite, but some have the opposite, a craving for comfort foods leading to weight changes. So, either weight loss or weight gain, we want to pay attention to. There's psychomotor retardation, and this refers to slowed movements, speech, or reactions observable by others. This is a hallmark of severe depression. And then there's suicidal thoughts. So, depression is a major risk factor for suicide, with over half of suicide deaths linked to depressive episodes. So, when working with clients experiencing depression, consider how these symptoms interact. For instance, a client might report trouble concentrating at work due to poor sleep, which feeds feelings of failure and hopelessness. This cascading effect highlights the importance of addressing underlying issues like sleep or nutrition as part of the treatment plan. And because I'm an art therapist, I just want to make sure that I'm talking so much more about art therapy in these videos. But looking at it from an art therapy context, clients can externalize their feelings through creative expression. So, for example, using a series of paintings to explore their emotions might reveal patterns of self criticism or sadness that they struggle to articulate verbally. And moving on to persistent depressive disorder, it's also called dysthymia. So it's a longer lasting form of depression. So the description is in the title. Persistent is the key word here. And for adults, symptoms must persist for at least 2 years, and for children or adolescents, 1 year. And unlike MDD, persistent depressive disorder tends to be chronic and less severe, but it significantly impacts quality of life. Clients might describe this as a constant undercurrent of sadness or hopelessness, and symptoms include low energy, poor self esteem, impaired decision making, appetite changes, and abnormal sleep patterns. And one unique aspect of persistent depressive disorder is double depression, where a person with persistent depressive disorder experiences episodes of major depressive disorder. And these clients often describe feeling like they've never been happy, punctuated by periods of feeling even deeper despair. Disruptive mood dysregulation disorder applies to children aged 8 to 16, with a hallmark feature of persistent irritability and frequent intense temper outbursts. These outbursts occur at least 3 times a week across multiple settings for at least 12 months. And while disruptive mood dysregulation disorder overlaps with other disorders like MDD, it is distinct in its focus on chronic irritability rather than episodic mood changes. In practice, distinguishing disruptive mood dysregulation disorder from typical childhood behaviors can be tricky. For example, a child displaying irritability only at school might be reacting to a specific stressor rather than meeting the pervasive and persistent criteria of disruptive mood dysregulation disorder. So in the DSM, there's multiple specifiers for depression, and depression can present in different forms, and the DSM-5-TR includes these specifiers to help capture the diversity of the diagnosis. So starting with melancholic depression, this is severe, non-reactive episodes marked by neurovegetative symptoms like psychomotor retardation and significant weight loss. This is often treated with more intensive interventions such as electroconvulsive therapy. So this is the client that just can't get up, just can't get moving, just can't get the motivation or the energy to start their day. Then we have atypical depression characterized by mood reactivity, increased appetite, hypersomnia, and physical heaviness, or what's also called leaden paralysis. So I've heard that described as just sort of feeling like your body is stuck in a wind tunnel and it takes so much energy just to make any small movement, and just feel like you're wearing like lead weights on your feet and your hands and in your head. You just kind of can't move the way that you want to. You don't feel free. So, sensitivity to rejection is also common and might point to underlying attachment or personality issues with this one. Another specifier is postpartum depression. So, it doesn't have its own diagnosis, it's going to nestle underneath as a specifier in the depressive disorders category. And that occurs within weeks of childbirth, influenced by hormonal changes and sleep deprivation. And for this one, we want to rule out thyroid dysfunction too. So, they're going to see their medical team to rule that out. We have seasonal depression, also known as seasonal affective disorder. And again, this is a specifier, it's not a standalone disorder. And it's linked to decreased sunlight during winter, treatable with light therapy. So, symptoms of this include low energy, excessive sleep, weight gain, and depressed mood. And living in Pittsburgh, it's located at a northern latitude with long gray winters and limited sunlight. And the city averages just 59 sunny days annually, which really exacerbates the risk for seasonal affective disorder among residents. So, if you're living in this general area, you want to pay a lot of attention to your clients over the winter months and make sure that you're continuously checking for symptoms and low mood due to the changes in the weather and the changes in sunlight. So, like I said, the treatment options are light therapy. So, a standard treatment involving daily exposure to a light box that mimics natural sunlight for 20 to 30 minutes. You can also look at lifestyle adjustments, so increasing outdoor activity during daylight hours, using dawn simulating alarms, and maintaining a consistent sleep schedule can help. Can also look at vitamin D supplementation. So, again, they want to reach out to a medical professional to make sure that this supplement would be useful for them. But that could address some deficiencies common in areas with limited sunlight. You can also look at cognitive behavioral therapy tailored specifically for seasonal affective disorder or medications like SSRIs that we're going to talk about in a bit. That can be helpful in more severe cases, even if it's just short term. Maybe we start in October and we end in April, and that's just a reoccurrence that we try every year to make sure that seasonal affective disorder symptoms are well treated. And then the final specifier for depression that the DSM identifies is psychotic depression. So this includes delusions or hallucinations requiring both antidepressants and antipsychotics for treatment. And then talking very quickly about causes and risk factors. Depression is a multifaceted condition with biological, psychological, and social contributors. Key risk factors include neuroticism, so a personality trait marked by heightened sensitivity to stress. While stable over time, neuroticism can stem from early trauma or adverse childhood experiences. For clients with high neuroticism, screening for PTSD or complex trauma can provide deeper insights. You also want to take a good family history. A genetic predisposition often increases vulnerability to depression. And we're looking at medical conditions too. So, autoimmune disorders, chronic illness, and even conditions like hypothyroid can exacerbate depressive symptoms. And finally, we want to look at social and systemic factors. Unresolved trauma, ongoing stressors, and a lack of access to basic needs like sleep and nutrition play significant roles. So, by presenting depression as more than a checklist of symptoms, you can help clients see their experience in a broader context. Whether through talk therapy, creative expression, or addressing physiological factors, the goal is to meet clients where they're at and tailor interventions to their unique stories. And I also want to make sure that we're talking about the neurobiological underpinnings, or really what's going on in the brain. So, mood disorders like depression and bipolar disorder are deeply tied to the neurobiological processes that influence both the brain's structure and function. The hypothalamic pituitary adrenal, or HPA axis, plays a critical role in regulating stress. In individuals with mood disorders, the HPA axis often becomes dysregulated, leading to chronic stress responses that increase cortisol levels and contribute to neuroinflammation. This persistent inflammation can damage neurons and impair the brain's ability to adapt and heal, exacerbating mood symptoms. Neurotransmitter imbalances are central to mood disorders. Low levels of serotonin and norepinephrine are associated with depression, while dopamine dysregulation contributes to anhedonia, or that loss of pleasure, and motivational deficits. Structural changes in the brain also play a role. So, for instance, that prefrontal cortex, responsible for decision making and emotional regulation, often shows reduced volume or activity in individuals with depression. The amygdala, which processes emotional stimuli, can become hyperactive, leading to heightened sensitivity to negative experiences. In bipolar disorder, dysregulated neural circuits contribute to rapid shifts between depressive and manic states, with abnormalities in connectivity between the amygdala, prefrontal cortex, and other key regions. And emerging research highlights neuroplasticity, or the brain's ability to reorganize and adapt, as a promising area for intervention. So, treatments like antidepressants, psychotherapy, and even lifestyle changes such as exercise to promote neurogenesis, particularly in the hippocampus, which is often smaller in individuals with depression, can really start to make a difference. So, talking about treatment for depression, it typically involves psychotherapy, medications, or a combination of both. Research consistently shows that combining therapy and medication often leads to the best outcomes, reducing the average length of a depressive episode from 6 months to less than 3. However, treatment is not a one size fits all approach, and individualizing care is essential. So, starting with psychotherapy, among one of the most studied approaches is cognitive behavioral therapy, which helps clients identify and break the cycle of negative thoughts, emotions, and behaviors. For example, a client might work on challenging their self critical thoughts, like believing they're worthless after a job rejection, by reframing these thoughts and exploring alternative perspectives. For clients hesitant to engage in talk therapy, art therapy, or other creative approaches can be valuable. We also want to look at medications. So, antidepressants aim to increase the availability of neurotransmitters like serotonin, dopamine, and norepinephrine in the brain. While effective for many, these medications require time to work, often up to 2 months for full benefits. Treatment response tends to follow the rule of thirds. One third of individuals experience full remission, one third see partial improvement, one third see little to no benefit from initial treatments. And for treatment resistant depression, interventions like electroconvulsive therapy may be considered. And while electroconvulsive therapy might sound intimidating, it's among one of the most effective treatments for severe depression. For example, I had this client with severe persistent depression who found so much relief through treatments of electroconvulsive therapy after multiple failed trials of antidepressants. And so, speaking of antidepressants, let's talk about some of the common classes of antidepressants. So, we're going to start with selective serotonin reuptake inhibitors, or SSRIs. And this includes name brand medications like Celexa, Lexapro, Paxil, Prozac, and Zoloft. And you've probably seen ads run on the TV for a lot of these. And these are often first line treatments due to their efficacy and relatively mild side effects. So if somebody's just going to try an antidepressant for the first time, the likelihood that they're going to get prescribed one of these is pretty high. And then we look at serotonin and norepinephrine reuptake inhibitors, or SNRIs. And this includes Effexor, Pristiq, Cymbalta. And Cymbalta is also really effective for nerve pain. So if you have somebody with chronic pain and depression, usually Cymbalta is a good one to try. Then there's the tricyclic antidepressants. That includes Elavil. And these are used less frequently due to side effects, but effective when newer medications fail. And then we've got the monoamine oxidase inhibitors, or MAOIs. This includes Nardil, Parnate, and MSAM, and that's a skin patch to wear. It's not a pill to take. And while these are effective, MAOIs require dietary restrictions to avoid dangerous interactions with foods like aged cheese or meats. And there's some other medications to know about. Wellbutrin's really popular right now, and it's unique among antidepressants as it's primarily affecting norepinephrine and dopamine rather than just serotonin. And this mechanism of action makes it a valuable option for clients who don't respond well to SSRIs or SNRIs. It's less likely to cause sexual side effects, which can be a significant barrier to adherence with other antidepressants, and it may help with energy levels and motivation, making it particularly beneficial for clients with low energy or anhedonia. And while Wellbutrin is generally well tolerated, it can increase the risk of seizures at higher doses, so it should be used cautiously in clients with a history of seizures or with significant alcohol use. And as far as emerging treatments go, there's so many advances happening all the time in neuroscience and psychiatry, and we're opening new avenues for treating mood disorders. So there's transcranial magnetic stimulation, or TMS. And this is a non invasive technique that uses magnetic pulses to stimulate specific areas of the brain, particularly the dorsal lateral prefrontal cortex. Blah, it's a mouthful. TMS is FDA approved for treatment resistant depression and is showing promise for bipolar depression too. Its benefits include minimal side effects and the potential to improve neural connectivity. And there's deep brain stimulation, and this is an invasive technique. It involves implanting electrodes to specific brain regions, such as the subgenual cingulate cortex, to regulate abnormal activity. Deep brain stimulation is being studied for severe treatment resistant depression and has shown promising results in clinical trials, though it still remains experimental. Then there's Spravato, or esketamine. And Spravato is a nasal spray formulation of esketamine, a derivative of ketamine, which works by modulating the brain's glutamate system. Unlike traditional antidepressants, it has a rapid onset of action, making it a breakthrough option for treatment resistant depression. Spravato is administered under strict supervision in a clinical setting due to potential side effects and the need for careful monitoring. It provides rapid relief of depressive symptoms, often within hours to days, and it's particularly effective for clients experiencing severe symptoms, including suicidal ideation. There are some risks and considerations to consider with this medication, and many clients report feeling disconnected or experiencing out of body sensations during or after treatment. And because of its similarity to ketamine, there's a risk of misuse or dependency, emphasizing the importance of controlled administration. And some side effects can include sedation, nausea, dizziness, and elevated blood pressure. So, again, the importance of doing this in a controlled environment where the client can be observed while they're taking it is really important. Some other emerging therapies to treat depression include psychedelics. So, research into psychedelics like psilocybin, found in magic mushrooms, and MDMA, also sometimes known as ecstasy, has shown promising results in treating treatment resistant depression. And these therapies are currently in experimental stages and are not FDA approved for widespread use. However, they're generating excitement in mental health fields for their potential to address longstanding symptoms when other treatments have failed. And how they work. So, psilocybin acts on serotonin receptors to promote a reset of rigid neural pathways associated with depression. Many participants report a sense of clarity and connection following treatment, often described as a profound emotional or spiritual experience. MDMA enhances the release of serotonin and oxytocin, which may help individuals feel more open and connected, reducing emotional defenses that hinder therapeutic process. And so, both of these are promising efficacy in clients with treatment resistant depression or trauma related depressive symptoms, and they might help clients gain insight into emotional and cognitive patterns contributing to their depression. But again, lots of risks and considerations. And again, these are not FDA approved. So the likelihood that you're going to see clients on these anytime soon is really low. But we want to know that they are contraindicated for bipolar disorder. So, psychedelic therapies are not advised for clients with bipolar disorder due to the risk of triggering mania, psychosis, or mixed episodes that we're going to talk about in a bit. Accurate diagnosis is critical before considering these interventions. And there's also psychological risks. Clients may experience challenging or destabilizing bad trips, which can exacerbate anxiety, paranoia, or the depression that we're trying to treat. And again, there's those legal and ethical concerns that we always have to keep at the forefront of our minds. So, outside of clinical trials, these treatments are not yet legal or regulated in most areas, which means you can't recommend them. But what you can do is provide psych education on the pros, the cons, the risks, the benefits. And then, as far as these new ones, the psilocybin, the MDMA, any of the psychedelics, there is a strong potential for misuse. These substances carry a risk of recreational misuse, particularly in unsupervised or unregulated settings. And then finally, there's emerging research on gut brain health. This underscores the importance of the microbiome in mood regulation. So, an imbalance in gut bacteria has been linked to depression through mechanisms like inflammation and altered neurotransmitter production. Probiotics, prebiotics, and dietary interventions are being explored as potential adjunctive treatments. The gut brain axis is a communication network between the gastrointestinal system and the central nervous system that plays a vital role in mental health. Gut microbiome, a collection of microorganisms in the digestive tract, influences neurotransmitter production, immune function, and the body's stress response. The imbalance of gut bacteria has been linked to increased inflammation and mood dysregulation, contributing to conditions like depression and bipolar disorder. So, probiotics show some promise in reducing depressive symptoms by increasing inflammation and enhancing serotonin production. For example, a 2020 review in Frontiers in Psychiatry found that probiotic supplementation improved mood and reduced stress markers in individuals with mild to moderate depression. Prebiotics, which nourish beneficial bacteria, can further support a healthy microbiome and regulate stress responses. Dietary interventions such as the Mediterranean diet, which is high in fiber, fruits, vegetables, and fermented foods, help maintain a balanced microbiome. Emerging treatments also include psychobiotic or probiotics specifically aimed at improving mental health. And while still in research stages, psychobiotics have shown some potential for reducing depressive and anxiety symptoms through anti inflammatory effects and improved neurotransmitter function. So, integrating gut health focused strategies with traditional treatments like therapy and medication can enhance outcomes, particularly for clients experiencing systemic inflammation or treatment resistant symptoms. Counselors can encourage clients to explore microbiome supportive diets, discuss probiotics, potential benefit, and collaborate with dietitians to create tailored nutritional plans. These holistic interventions empower clients to support their mental health through sustainable lifestyle changes. So, this is all really interesting to me because oftentimes I see clients who are a little hesitant to start on a medication to treat their depression or their anxiety or their bipolar just because there's so many side effects out there. So, if we can tackle everything that we need through nutrition, why not try that route? Plus, the likelihood that they're going to get better nutrition overall just to support higher energy levels and better physical health, it's all a plus. So we want to focus starting on like probiotic rich foods. So that might be like yogurt, kefir, kimchi, sauerkraut, miso, tempeh, and pickles. I love pickles. I could probably eat pickles all day, every day, but we got to watch for sodium for that. And then we want to look at those prebiotic foods to nourish the good gut bacteria. So bananas, garlic, onions, leeks, asparagus, chicory root. Think of anything that makes your pee smell really bad. That's going to be helpful. We want to look at fiber rich foods, whole grains, legumes, fruits, vegetables, foods high in omega 3 fatty acids like fatty fish, salmon, mackerel, sardines, anchovies, and walnuts. And then we can also look at fermented beverages too, like kombucha or apple cider vinegar. And there's also some research into some additional foods, and you might have heard the benefits of dark chocolate and green tea. For dark chocolate, you want to make sure it's 70% or higher, and that's going to positively impact your gut bacteria. But again, when you really think about that food pyramid or all the foods that you know you should be eating, eat those and then add some fermented ones in there too. I think kimchi is just, the best invention ever. I could probably eat pickles and kimchi. Maybe I'll do that. Maybe I'll go on a pickle and kimchi diet. But so that wraps everything up as far as depression goes. And I want to make sure that we are jumping into bipolar disorder too. So, bipolar disorder is a complex mood disorder that exists on a spectrum with three main types: bipolar I, bipolar II, and cyclothymic disorder. Historically referred to as manic depressive illness, bipolar disorder involves fluctuations between two poles, depressive and mania or hypomania. These episodes are interspersed with periods of euthymia where mood appears stable. However, even during euthymic periods, many individuals with bipolar disorder experience mood lability, a less noticeable but still impactful instability in emotional regulation. And it's crucial to emphasize that these euthymic phases don't always equate to a sense of well being. Individuals may not meet diagnostic criteria for a depressive or manic episode, but that doesn't mean that they feel normal or great. As clinicians, we need to help the public and sometimes even our clients understand that the in between phases of bipolar disorder still carry challenges and they shouldn't be minimized. So, before diving deeper into bipolar disorder, let's look at what it isn't. Misdiagnosis is common because other conditions can share overlapping symptoms, and a thorough assessment is essential to distinguish bipolar disorder from conditions like borderline personality disorder, substance use disorders, psychotic disorders, and even unipolar depression. So, that's just that one pole of depression. So, starting with borderline personality disorder, mood lability is a hallmark of borderline personality disorder, often leading to confusion with bipolar disorder. While both involve mood fluctuations, they occur for different reasons. Individuals with borderline personality disorder experience intense emotional reactions to perceived threats or relational stress. This is fueled by chronic feelings of abandonment, anxiety, and worthlessness, which can lead to self harm, suicidal ideation, or extreme shifts between idealization and devaluation of people or situations. For example, somebody with borderline personality disorder might adore their partner one moment but feel intensely betrayed the next due to a minor disagreement. While these emotional swings can resemble bipolar episodes, they are more reactive to external stressors and shorter lived than episodic patterns seen in bipolar disorder. It's also possible for somebody to have both bipolar disorder and borderline personality disorder, so a detailed clinical history is essential. And then substance use also complicates diagnosis significantly. Depressants like alcohol can mimic depressive symptoms, causing fatigue, poor concentration, sleep disturbances. Conversely, stimulants such as cocaine or amphetamines can trigger feelings of euphoria or hyperactivity, which resemble manic episodes. So, take, for example, a client who uses methamphetamine and reports that they're staying awake for days, engaging in risky behaviors, and feeling unstoppable. This might seem like mania, but if the symptoms subside after the drug is out of their system, it's likely substance induced rather than bipolar disorder. Diagnosis should only occur after the individual has been substance free for a sufficient period or if a clear pattern of mood episodes exists independent of substance use. And psychotic features can occur in both bipolar disorder and conditions like schizophrenia or schizoaffective disorder. In psychotic depression, for example, delusions or hallucinations are tied specifically to depressive themes, so feeling responsible for a global disaster. In schizophrenia, psychosis is more chronic and not necessarily linked to mood episodes. Assessing family history and identifying the timing of psychotic symptoms are key to making this distinction. For example, if psychotic symptoms only appear during a manic or depressive episode, they may indicate bipolar disorder with psychotic features rather than a primary psychotic disorder. And then I just want to talk about unipolar depression versus bipolar depression. So, bipolar depression differs from unipolar depression in critical ways, both clinically and in treatment. Antidepressants are commonly used for unipolar depression, such as SSRIs, but those can trigger manic or hypomanic episodes in individuals with bipolar disorder. This includes over the counter remedies like St. John's wort or supplements that you might see over the counter, such as SAMe, SAM, it's all in all caps, dash lowercase e, which clients might take without consulting with a provider or really knowing the risks. Educating clients about these risks is an essential part of treatment planning. And neurochemically, bipolar depression involves different mechanisms than unipolar depression, requiring mood stabilizers or atypical antipsychotics for effective treatment. Misdiagnosis can lead to inappropriate interventions and potentially exacerbate symptoms. So, the two poles of bipolar disorder, it's depression and it's mania on opposite ends of the spectrum. Depression, as we discussed earlier, is one pole of bipolar disorder. The symptoms of bipolar depression are similar to unipolar depression with pervasive sadness, fatigue, and anhedonia. However, bipolar depression is often more debilitating with higher rates of psychomotor retardation and suicidal ideation. The other pole of bipolar disorder is mania, and that's the one we haven't really talked about yet. It's defined by an elevated or irritable mood lasting at least 7 days or any duration if hospitalization is required. Symptoms of mania include distractibility, difficulty maintaining focus due to racing thoughts or environmental stimuli, insomnia. Unlike depression, insomnia in mania is marked by a decreased need for sleep, with the individual feeling energized despite little rest. So, the question that I usually like to ask here if somebody's telling me that they're not sleeping, I ask them, do you want to sleep? Do you feel like you need sleep and you just can't get sleep? Or do you feel like you don't need the sleep at all? And if somebody's telling me they can't sleep and they don't need sleep, I'm just earmarking that for myself because that would be a symptom of mania. There's also the symptom of grandiosity, so inflated self esteem or realistic beliefs about one's abilities. For example, a client might believe that they can start a multi million dollar business overnight, or maybe that they have supernatural powers. And you're also going to notice a flight of ideas and pressured speech. Thoughts race, and the person speaks rapidly, jumping from topic to topic without pause. And this can make conversations chaotic and hard to follow. I know I'm a fast talker, and you might even be listening to this on like 1.25 or 1.5 speed, making this go even faster. This is more to make sure that I am able to get all of this information in an amount of time that doesn't take up your entire life. So, while this might sound like an example of pressured speech, I assure you this isn't the speed that I normally talk at. And if you ever just want me to slow down, let me know and I can do that for you in the next videos that I record. Just drop a comment here. But the next symptom would be goal directed behavior. So, manic episodes often involve excessive pursuit of pleasurable or risky activities such as impulsive spending sprees, substance use, or risky sexual behaviors. And then finally, there's thoughtlessness. So, impulsivity and disregard for consequences driven by a craving for stimulation and excitement. So, for instance, a client experiencing mania might max out their credit cards on frivolous purchases, believing that they'll easily make the money back later. Or if you're in an art therapy setting, this might translate into grand, overambitious projects like attempting to complete a mural overnight only to abandon it when the manic episode ends. So, we already talked about some of the differential diagnoses for bipolar, but let's also specifically discuss the mania in bipolar and how it may sometimes be confused with these other diagnoses or vice versa. Symptoms of mania can overlap with these other disorders, requiring careful differentiation. So, starting with generalized anxiety disorder. Like mania, generalized anxiety disorder involves racing thoughts and insomnia, but the focus is on reducing anxiety rather than pursuing pleasure. And again, when you ask this person about their sleep, they're going to say, "Oh, yes, I'm so exhausted. I so much want to go to sleep, but my brain just can't shut off. I just can't go to sleep." So that's going to be a key point that you're going to notice of like, okay, well, that's not mania if they feel like they need sleep and can't get it. Then there's PTSD or CPTSD, and that's hypervigilance in PTSD can mimic mania's distractibility and energy, but it stems from a survival response rather than an elevated mood. And again, they're going to want to go to sleep, but just can't get to sleep or can't stay asleep. And then there's ADHD. So, impulsivity, hyperactivity, distractibility, and ADHD can resemble mania. But ADHD symptoms are chronic and not episodic, meaning they don't come and go. They're really just going to be there all the time, pervasively in every area of their life. Additionally, ADHD hyperfocus is often directed towards specific interests, while mania involves goal directed behavior across multiple areas. So, you know about depression and you know about mania, and you might think, okay, mix those two together and you've got bipolar, right? Well, not quite. Bipolar disorder comes with extra layers, making it more than just a simple combination of highs and lows. Everything about it exists on a spectrum, and diagnosing bipolar takes careful consideration of not just current symptoms, but patterns over a lifetime. And bipolar disorder has seen a significant increase in diagnoses, partly due to its expanded definition and the push for medication based management. And this can blur boundaries between bipolar disorder and other conditions like mood instability, impulsive behaviors, or personality disorders. And some researchers claim that as many as 40% of individuals seeing psychiatrists are diagnosed with bipolar disorder. And while that's an eye catching statistic, it highlights how important it is to avoid overdiagnosis. Not every fluctuation in mood points to bipolar disorder, and sometimes the real answer lies in another diagnosis entirely. So let's learn the language of bipolar. To diagnose bipolar accurately, we need to understand a few key terms that the DSM just loves to use. So there's hypomania, and this is a less intense version of mania. It requires at least 3 symptoms of mania lasting for at least 4 days. Hypomanic episodes don't cause clinically significant impairment, hospitalization, or psychosis, but they do represent a clear shift in behavior. And then there's rapid cycling. This term describes 4 or more mood episodes within a 12-month period. So it's not as fast as TikTok videos might suggest. Rapid cycling doesn't mean mood changes every 30 minutes. If you see ultra rapid mood shifts, you're more likely dealing with a personality disorder or substance related issue. And then there's something called mixed episodes, and this refers to experiencing symptoms of both poles, mania and depression, at the same time. For example, someone might feel hopeless and tearful while simultaneously having bursts of energy or impulsivity. One pole typically dominates, but breakthrough symptoms from the opposite pole can still appear. We want to make sure that we're tracking patterns over time. So, bipolar episodes can be years apart, which often leads to misdiagnoses. For example, a person might experience a single manic episode in their 20s, then remain relatively stable for a decade. Without a thorough life history, it's easy to miss the diagnosis or misattribute the symptom to another cause like substance use. So, just to give a client example, I was working with this client and I'm going to give him a pseudonym Jason. So, really, the only thing you know about him is that his name wasn't Jason. But Jason had been in treatment for opioid and alcohol use disorders, and he also struggled with a reoccurring behavioral addiction tied to sex. Every 8 to 12 months, Jason entered a hypomanic episode, and during this time, he'd become irritable, pick fights with his long term girlfriend, download dating apps, and pursue casual sexual encounters. Before he got sober, these hypomanic episodes often led to relapses with alcohol and pills. Jason consistently denied suicidality, but his behaviors during hypomania put him at risk in other ways. Over years of working together, we identified the warning signs of his hypomanic pattern and developed a safety plan to the point where we could almost start to predict when this might happen. When Jason started exhibiting grandiose ideas or irritability, we jumped straight into crisis prevention, much like you do for a client with a history of suicidal ideation. Recognizing and tracking these patterns over time is key to effective intervention. So now that we know a little bit about bipolar disorder, let's look at the specific types. So there's three. There's bipolar I, bipolar II, and cyclothymic disorder. Bipolar I requires at least one full manic episode in a lifetime. A depressive episode is not required, but many people with bipolar I do experience depression. For example, if somebody has a manic episode where they feel invincible, spend recklessly, and experience racing thoughts, but no depressive episodes, they still meet criteria for what we call bipolar I. Bipolar II is defined by at least one major depressive episode and one hypomanic episode. Hypomania doesn't cause significant impairment, but it still represents a noticeable change. So, a client might describe feeling on top of the world during a hypomanic episode, starting projects, socializing, and thriving, followed by a crash into deep depression. This would be bipolar II. And cyclothymic disorder involves chronic, low grade mood instability for at least 2 years or 1 year in children or adolescents. Symptoms never meet full criteria for mania, hypomania, or major depressive symptoms, but still cause distress. So think of it as a long term hypodepression with sprinkles of hypomania. And some misconceptions about bipolar. It doesn't alternate predictably. Bipolar doesn't follow this like neat depression mania, depression mania, depression mania pattern. Triggers for mood shifts can vary widely and often don't follow a specific rhythm. And euthymia isn't always what it seems. During euthymic periods, people may appear symptom free, but still struggle with mood instability or low grade symptoms. Relief from depressive episodes can sometimes resemble hypomania due to increased energy and motivation. And I have another client, we'll just call her Maria because it's just one letter off from mania. And this is a client, she was diagnosed with bipolar II disorder. Maria came to therapy feeling depressed and mentioned bursts of energy during her depressive episodes. For example, she described a week where she couldn't stop reorganizing her house, only to crash into exhaustion and hopelessness. And these bursts of activity weren't enough to be considered mania, but they represented mixed features, a hallmark of her bipolar pattern. Recognizing this nuance helped us refine her treatment plan, ensuring that we were addressing both poles effectively. And depression carries a significant mortality risk, with mood disorders being present in the majority of individuals who die by suicide. Up to 5% of people with depression will ultimately take their own lives. Beyond suicide, depression can worsen outcomes for illnesses like cancer, heart disease, and stroke, reducing life expectancy by up to 10 years, even when suicide isn't a factor. For individuals with bipolar disorder, the statistics are even more alarming. Suicide risk is approximately 10 to 30 times higher than the general population. Recognizing and addressing the risk is one of the most critical responsibilities of a counselor. So, understanding suicide statistics. So, here's some data points to give context to the scope of the issue. Racial disparities. So, between 2014 and 2019, suicide rates increased by 30% among Black individuals and 16% among Asian or Pacific Islander individuals. And looking at pandemic trends from 2019 to 2020, during the onset of COVID-19, the overall suicide rate declined by 3%. And this counterintuitive finding has sparked debates. So I wonder what your hypothesis is for this drop. I definitely have my own thoughts on what was happening here. We also want to make sure that we're focusing on transgender individuals. So, among those who identify as transgender, 42.9% report depression and suicidal ideation, and 29.1 report at least one suicide attempt. We also want to make sure we're looking at that postpartum period. Suicide risk is significant for both mothers and fathers. Mothers with postpartum depression report 12% suicidal ideation, while fathers with postpartum depression have a 21% increased risk, rising sharply to 46 times the risk if mixed features are present. And also, there's some really interesting facts about seasonal patterns. So, if I ask you at what time of the year is suicide most common, you probably have an assumption here. And let me just blow your mind. So, suicide rates peak in the spring and the summer, not during the holidays as commonly assumed. Hypotheses suggest that this may stem from the contrast between the vibrant external world and the individual's internal despair. For those with seasonal affective disorder or major depressive disorder with seasonal patterns, dehydration and disruptive medication efficacy may also play a role. So here's your reminder: drink water, drink all the water, drink so much water, stay hydrated. It makes a difference in your mood. So, when talking about suicide, we want to make sure that we're assessing for suicide, especially when working with clients diagnosed with depression, bipolar disorder, or other co occurring conditions. So, here's some tips to guide your approach. You want to ask directly. It's a myth that asking about suicide puts the idea in someone's head. Be straightforward and compassionate. Have you ever had thoughts of wanting to die or hurt yourself? Sometimes people who feel the way that you're describing think about suicide. Have you ever had thoughts like that? You want to assess for specifics too. If a client indicates suicidal thoughts, follow up with questions to determine intent, plan, means, and time frame. Do you have a plan for how you would want to hurt yourself? Do you have access to the things that you would need to carry out your plan? And you also want to gauge risk factors. So pay attention to red flags like high risk times. So transitioning out of a depressive episode or into mania or hypomania often brings energy and impulsivity that increases risk. You want to look at historical patterns, so ask about past suicide attempts, particularly during depressive or mixed episodes, and co occurring conditions. Consider PTSD, substance use, or borderline personality disorder, which elevates risk in clients with bipolar disorder. And you also want to use empathy to build trust. So you could say, "Hey, I know it feels overwhelming to talk about this, but I want you to know that I am here to help, not to judge." And these feelings can be incredibly heavy. You don't have to carry them alone. I'm here to help. Suicide prevention starts with screening and safety planning, which should be integral to every clinician's toolkit. Screening involves direct but empathetic questions such as, have you had thoughts about ending your life? If a client acknowledges suicidal ideation, follow up with those specific questions about intent, plan, and access to means. Role playing these conversations can help you build confidence in broaching the sensitive topic. Safety planning includes removing access to lethal means, identifying support systems, and creating a list of coping strategies that the client can use during crisis. So, we're talking about prevention. It's also important to talk about postvention. So, it's equally important for supporting families and communities after a suicide. Counselors can facilitate grief support groups, offer psychoeducation about grieving process, and help survivors navigate their feelings of guilt or anger. Emphasizing a non judgmental and compassionate approach during postvention ensures that survivors feel supported and less isolated. Additionally, advocating for systemic changes such as increased mental health resources or suicide prevention education can create lasting impacts on a community level. So, I want to just share a story about Emily. She's a client with bipolar I who came to therapy after a depressive episode, and her mood improved and she gained energy. Emily began showing signs of mania, taking on multiple projects, spending impulsively, becoming irritable. One session, Emily mentioned feeling invincible and casually joked about driving her car into the river just to see what would happen. This was a pivotal moment. I gently asked, "Hey, Emily, that sounds serious. Have you ever thought about hurting yourself in other ways?" And she admitted that during her lows, she had planned how she wanted to end her life, but hadn't acted because she lacked the energy. Now, with her increased energy, the risk was much higher. So, we moved immediately into safety planning. So, removing access to lethal means. Emily agreed to hand her car keys to her boyfriend temporarily. And she agreed to allow me to call him on the phone as her emergency contact and talk about what I was noticing and what was going on so that he was in the loop. We established a support network. So her sister and a crisis hotline were added to her plan and put on speed dial. I made sure that she had both numbers. I made sure that her sister knew what was going on too. And then we also created a structure for her day to manage impulsive behaviors. And this looked a lot like her stepping up in level of care. So instead of coming to group only once a week, she started coming to group multiple times a week to make sure that she had something productive to do with her days. and an open and not judgmental place to talk about her feelings. And so, this collaborative approach helped to de escalate the immediate risk and reinforce the therapeutic alliance. I worked with her. I didn't tell her what to do or how to do. We created these goals together. So here's some key considerations for bipolar disorder and suicide. We want to focus on dangerous times. Clients with bipolar disorder are at a higher risk during transitions, coming out of a depressive episode or entering mania. Increased energy and goal directed behavior can amplify impulsivity and access to means. We also want to look at mixed episodes. When symptoms of depression and mania overlap, risk skyrockets. For example, a client might feel hopeless but energized enough to act on suicidal thoughts. And we also want to do some long term monitoring. Even if suicide risk feels immediate, remember to track patterns over time. Regular check ins about mood and safety are critical. And suicide screening isn't just about identifying immediate risk, it's about building a culture of openness where clients can feel safe discussing their darkest thoughts. Your willingness to ask the tough questions could save a life. And moving into cultural considerations, cultural beliefs and stigmas significantly impact how mood disorders are understood, expressed, and treated. In many cultures, mental health issues are not viewed through the lens of biology or psychology, but as moral, spiritual, or social concerns. For instance, individuals from collectivist cultures may frame depression as stress or fatigue, stemming from family or societal pressures, rather than a diagnosable disorder. And this cultural framing can delay help seeking behaviors as individuals may prioritizing maintaining harmony or avoiding shame over addressing their personal well being. Additionally, stigma around mental health is pervasive in many communities, especially among ethnic minorities, where acknowledging a mental health issue can be seen as a personal failure or a sign of weakness. Culturally competent approaches to therapy are essential to overcoming these barriers. Clinicians must understand how cultural values shape the client's perception of mood disorders and tailor interventions accordingly. For example, integrating family or community into treatment plans can be particularly effective for clients from collectivist backgrounds as it aligns with their value systems. Using culturally adapted psychoeducation to normalize symptoms and reduce stigma is another powerful tool. For instance, framing depression as a common response to stress and offering metaphors that resonate with a client's culture, likening emotional strain to physical injury, can help bridge understanding. Additionally, providing treatment in the client's native language or connecting them to culturally matched providers can enhance trust and reduce barriers to care. In populations with limited access to healthcare, cultural competence also means addressing systemic inequities. Counselors should advocate for affordable care options, support clients in navigating complex healthcare systems, and consider the influence of structural barriers like poverty, discrimination, and lack of transportation on treatment adherence. By combining cultural humility with advocacy, clinicians can create more inclusive and effective therapeutic environments. Social support, socioeconomic factors, and access to healthcare are deeply intertwined in the onset, progression, and management of mood disorders. A lack of social support is a well documented risk for depression and can exacerbate symptoms of both depressive and bipolar disorders. For instance, individuals who feel isolated or lack meaningful connections may experience prolonged episodes due to absence of emotional or instrumental support during difficult times. Conversely, strong social networks can act as a protective buffer, offering encouragement, accountability, and resources to help clients manage their symptoms. Socioeconomic factors play a pivotal role in mental health outcomes. Poverty, food insecurity, and unstable housing create chronic stress, which lead to or worsen mood disorders. For example, a client struggling with unemployment and depression may find it difficult to focus on therapy goals when their basic needs are going unmet. These socioeconomic stressors not only increase vulnerability to mood disorders, but also make recovery more challenging, as clients may lack the resources to access consistent care, purchase medications, or participate in therapeutic activities like exercise or mindfulness. Access to healthcare is another critical determinant. Many individuals with mood disorders face significant barriers to care, including cost, lack of insurance, and provider shortages. Rural areas, for instance, often lack mental health specialists, forcing clients to travel long distances or forego treatment altogether. Additionally, systemic inequalities to healthcare disproportionately affect minority populations who may encounter discrimination or cultural insensitivity when seeking help. Addressing these issues requires a multi level approach. Clinicians can advocate for systemic change, work with clients to identify community resources, and use telehealth or other innovative solutions to reach underserved populations. So, by understanding and addressing these psychosocial factors, counselors can create more personalized, empathetic, and effective treatment plans, empowering clients to leverage their social networks, navigate systemic barriers, and meet their basic needs can significantly improve both their mental health and overall quality of life. And I know we talked about treatment for depression, but we didn't talk about treatment for bipolar disorder. So here we go. Treating bipolar disorder is more complex due to its biochemical underpinnings and the need to address both poles, both mania and depression. Medications play a central role, often combined with therapy, lifestyle interventions, and wellness strategies. So, medications, we've got antipsychotics, and that includes risperidol, Zyprexa, Seroquel, Geodon, and Abilify. And these medications stabilize mood swings and are especially effective during acute manic episodes. Then there's the mood stabilizers. So that's medications like lithium, Depakote, and Lamictal. And then there's also the antidepressants that we talked about for the unipolar depression. And these are sometimes used cautiously in combination with mood stabilizers or antipsychotics to avoid triggering manic episodes. One of the biggest issues with bipolar treatment is medication adherence. Many clients stop taking their medications once they feel better, thinking that they no longer need them. For example, I worked with Alex, who stopped taking his mood stabilizers after 6 months of stability. And within weeks, he experienced a manic episode leading to risky behaviors and hospitalization. So, educating clients on the importance of continued treatment, even during euthymic phases, is vital. Additional treatments for bipolar disorder include lifestyle interventions. So, we want to look at circadian rhythm regulation. Chronobiological treatments like melatonin or sleep aids help reset disrupted sleep cycle after episodes. Also, want to look at blood sugar management. So, stabilizing A1C levels and reducing oxidative stress can lower the frequency of episodes. And this can be done through nutrition or other medications that they might be able to get through their primary care physician. We can look at stress management, so techniques like mindfulness and vulnerability prevention reduce the likelihood of triggering symptoms. And we can also do increased self efficacy. Helping clients feel in control of their symptoms fosters hope and empowerment. For instance, developing wellness plans tailored to their specific symptoms, like tracking sleep patterns or creating daily routines, can give clients a sense of greater agency. We want to pay attention to medication non adherence. So, like I said, sometimes when clients do really well, they stop taking their medication. So, approving medication adherence in clients with mood disorders requires a combination of strategies tailored to individual needs. Psychoeducation can demystify the purpose of medications, explaining their role in mood stabilization and the importance of consistency for effectiveness. Family involvement can also foster accountability and provide support, particularly for clients who struggle with self management. And for clients who frequently miss doses, we can look at long acting injectables for antipsychotics, and that offers a practical solution, ensuring that therapeutic levels are maintained over weeks or months without daily dosing. Clinicians can also use motivational interviewing to address concerns about side effects or stigma, helping clients feel more engaged in their treatment plans. And talking about treatment plans should be as unique as the individuals that you're working with. Not everyone with bipolar disorder or depression has the same symptoms, triggers, or responses to treatment. So here's how to approach personalization. We want to make symptom specific plans. Start by identifying the most disruptive symptoms for the client. So, for instance, if insomnia is a major issue, we're going to prioritize circadian rhythm interventions. We also want to make sure that we're paying attention to holistic wellness. And holistic wellness approaches to mood disorders address not only the mind, but also the body and the spirit, integrating complementary practices alongside traditional therapies. So, mind body practices like yoga, Tai Chi, and mindfulness meditation have demonstrated effectiveness in reducing depressive symptoms and stabilizing mood. Yoga, for instance, has been shown to lower cortisol levels, increase GABA activity, and enhance overall well being. Tai Chi combines physical movement with meditative focus, promoting relaxation and improved emotional regulation. These practices also help clients reconnect with their bodies, counteracting the physical disconnection often experienced during depressive episodes. When we're talking about holistic wellness, we also want to make sure that we're talking about lifestyle interventions. So, again, exercise has a well documented positive effect on mood disorders, supported by studies showing its ability to boost neurotransmitters like serotonin, dopamine, and endorphins. We already talked about the role of nutrition, pickles and kimchi. We also want to look at low levels of vitamin D, increased omega-3 fatty acids. And there's also some research out there specifically about zinc and magnesium deficiencies are sometimes notable contributors to bipolar disorder. So sometimes just sending somebody to get some blood work done and get some quantitative data on what's going on with their nutrition can be really helpful. Can also look at acupuncture as an adjunctive treatment that's been studied for depression and anxiety. And you can also use digital tools. These are really transforming holistic care. So, apps like MoodPath, Headspace, MyStrength, these are going to help clients track mood changes, medication adherence, and therapy goals. And you can do wearable devices like Fitbit, Apple Watch. These are going to monitor sleep, activity levels, heart rate variability, and provide some real time data for clinicians and doctors to personalize these treatment plans. And finally, you want to build hope. Celebrate small victories with clients. For example, one client felt empowered after implementing a simple mindfulness routine to manage stress on a daily basis, and that decreased the frequency of depressive episodes. So we celebrated creating that habit of mindfulness, but we also celebrated just creating a habit at all. So, to summarize, depression characterized by persistent sadness, hopelessness, and loss of interest is far more than a mental health condition. It impacts the entire body. It increases mortality rates, worsens medical conditions for illnesses like heart disease, stroke, and decreases life expectancy by up to 10 years. The connection between depression and the body is bidirectional. Stress and depression can disrupt the vagus nerve, alter the gut microbiome, and lead to systemic inflammation and nutritional deficiencies, creating a vicious cycle. Addressing these psychological factors is crucial as addressing the psychological aspects. Depressive disorders frequently coexist with trauma histories, personality disorders, and other mental health conditions, emphasizing the importance of treating the whole person. This means attending to the emotional, cognitive, and physical components of depression while exploring the roles of trauma, systemic stressors, and environmental influences. Bipolar, with its distinct mood swings between depression and mania or hypomania, presents additional complexities in diagnosis and treatment. The spectrum of bipolarity includes rapid cycling, mixed episodes, and varying symptom intensities. Recognizing subtle patterns across a client's lifetime is essential, as misdiagnoses or missed diagnoses can delay treatment and heighten risks such as suicidality and impulsive behaviors. Counselors play a vital role in helping clients navigate the challenges of depression and bipolar disorder. Beyond recognizing symptoms, counselors must adopt a holistic, client centered approach that acknowledges each person's unique experiences, strengths, and needs. Treatment should be guided by evidence based practices, cultural sensitivity, and a commitment to addressing a broader psychological and systemic factor that influences their mental health. As future counselors, I challenge you to critically assess your own biases and remain curious. Explore how stigma, cultural differences, and systemic inequalities might affect your clients' experiences and access to care. Stay committed to being client centered, treating each individual with empathy and respect. Lastly, never stop learning. Whether it's keeping up with emerging treatments or refining your suicide prevention strategies, your dedication to growth will directly impact your ability to provide meaningful, life changing support. And let this work inspire you not only to make a difference in individual lives, but to advocate for change within systems that perpetuate barriers to care. Your efforts matter, and your compassion can save lives. If you have any questions, please reach out or comment below. I am happy to jump in and have a conversation with you about anything that this might have piqued interest in. Thanks.